Okay, thank you very much. I want to thank the organizers for the honor of the invitation to speak, as well as the panelists for hosting. I'm in Cincinnati. My name is Alex Doan, I'm in the U.S., and I really enjoy treating the periocular area, and I want to share a few things about how we approach the rejuvenation in that area, in particular focusing on volume restoration, and that can be incorporated with surgical procedures or as a standalone. The emphasis is mainly on fat transfer to achieve this, but you can, as we'll discuss, achieve similar results with synthetic fillers without downtime. I am a trainer for Galderma and Allergan in the U.S. as well as a consultant for Mertz, but I'm not going to talk about any of their products today, and I receive no compensation for this conference. So I really like this figure which shows the comparison split face, obviously, between an older on the left and a more youthful periorbital region. And we all talk and learn classically about the descent of the brow, increase in skin, the elastosis of the skin, which can be modified by brow lifting and upper bleph respectively. And many talk about the volume loss that occurs in the infraorbital region, so I won't belabor that too much. But what I do want to point out is the hollowing that occurs also in the upper, so in the superior periorbital region as well, which creates, and it begins medially and extends laterally. Perhaps she has just a little bit of it here, but it effaces or gets rid of the nice double contour or double parallel line of the upper lid and the supratarsal crease or supratarsal fold, which in the youthful face covers all but a couple of millimeters of the upper lid. So you see we have loss of that here, and if there was flash, you would see most of, or a brighter flash, you'd see most of that upper lid. So if we go a little deeper, what occurs in the bone? We know that bony loss occurs with age, and the orbit is no exception. What happens, though, is it expands. So the hollowness expands. The area of the hollowness expands radially outward. And what does that mean, or why is that important? Well, if we're doing a brow lift, and our goal is to, as we learn classically, to have it end up at starting and ending on the superior orbital rim, then our target is insidiously going upward with age. So if we basically can continue to chase that target cephalically such that the brow ends up being falsely elevated, I think, relative to a natural position of the brow. And there's also a nice example how it begins medially and then extends laterally with time. If we look at what might be an ideal youthful brow height above the lid, well, I think we'd all agree these are pretty youthful faces, and if we look at the height of the brow above the upper lid, it's probably no more than the height of the palpebral, or the palpebral fissure height. So the distance between the lids is greater than the distance from the upper lid to the brow, or at least the same, not more. Likewise, this mother-daughter image, you could argue this is a more aesthetically pleasing arch, but is it necessarily a younger brow when her daughter has a bit of a taper downward? I enjoy doing brow lifts. I think they have a great place in our practice, but I just want to point out some sort of challenges to conventional thinking about what a youthful brow is. We do see highlights beneath both their brows, so she hasn't aged sufficiently that she loses the highlight, but nonetheless a down-slanting brow isn't necessarily an aging phenomenon. So this is a typical patient that would come to our office requesting rejuvenation, and you can see that she has a fair amount of hollowing in here, as well as the upper lid skin excess and descent of the lateral brow, and loss of volume in here, in addition to what we mostly consider pseudoherniation or pushing forward of the lower lid fat, which is more exposed by this loss of volume in the infraorbital rim, of course, and midface. But again, focusing on the upper orbital rim, by addressing this hollowness, I think you can create a more youthful volume contour in that area. These are the typical markings we would use for revolumization with fat transfer, addressing the superior orbital rim here. She was also marked for an upper bleph, so please disregard that. I would not fill that area. Infraorbital rim, including the dots for the high point, or in this case the depth of the infraorbital rim, which we'll try to make higher, and the anterior and lateral cheeks, and we do typically blend into the temples, as we'll show. And so she was able to achieve, I think, a nicer highlight in the supraorbital region, and that created some elevation of the brow. We did do a lateral brow lift, a temporal subcutaneous brow lift on her, but nonetheless, I think that frames the eye better, as some call it, creating more highlight around the eye to make it look more youthful. 3 cc's for the supraorbital rim, 3 for the infraorbital rim. We also did the cheeks and lower face as well to round it out. But 4 years later, she still has retention of volume. So for those who think it doesn't last, I won't belabor all the points of fat transfer, but we do use centrifugation. It's sort of it's a Coleman adaptation, but gentle management and centrifugation to get rid of the supernatant and infranatant free fatty acids and blood and lidocaine. We transfer it then into 1 cc syringes and use just 0.9 and 1.2 millimeter cannulas. Injecting only on withdrawal is important, especially around any vessels, and I won't belabor where what all the locations of the periorbital vessels are, but we should definitely know those and stay more superficial to those. Just submuscular is the most often cited safe place for it. Multiple passes and multiple planes, as other speakers have discussed, in order to maximize the proximity of your fat to the blood vessels. If you have a glob of fat, the vessels can't get into the center of it, much like an abscess can't be treated effectively by antibiotics. So yeah, very slowly, only about 2 to 5 passes per 0.1 cc. Despite that, it goes pretty efficiently. The equipment's inexpensive. Patients are very satisfied in our hands, and it's natural stuff, so they really appreciate that. There's longer downtime, 2 to 3 weeks, typically about 2 weeks, and that second week is the part that can be a factor for patients in deciding whether or not to do it. And you might need to repeat it at a year. It is easily combined with other procedures. So I just want to show a few examples in the remaining time of sort of the continuum of lipoatrophy that we see in our practice anyway. So mild example here where she just has some infraorbital hollowing. She does have some supraorbital hollowing, and I wish I had injected that, but maybe if she comes back we'll do that again or do it with some filler. But at any rate, she was at least as pleased with her midface improvement as she was with her jawline improvement. I'll show the 3/4 view in a second, but 3 cc's for the infraorbital rim and a little bit in the lateral canthus, and then we did the cheeks. So I like the 3/4 view because you can really see the opposite cheeks, you know, the OG or double OG. Moving along the continuum, for moderate atrophy, this patient had fat transfer as well as face and neck lift and upper lids then, and she had we did address the upper orbital rim with 2 cc's, and then the same 3 cc's for the infraorbital rim. More advanced atrophy, and we ended up using 3 cc's for the supraorbital rim and 4 for the infraorbital rim. She had some asymmetry natively. She raises her brow, but nonetheless I can go back and tweak that a little bit with HA filler if we want, or a second round of fat transfer, but she was very pleased with that. And then lastly, this one was the most that we did in the supraorbital rim area, just very hollow. We consider that a hollow dominant patient, as opposed to some which may be skin dominant, where the upper orbital aging might be dominated by skin excess as opposed to volume loss. This is more on the hollow dominant side, obviously. So with no brow lift, she actually did get a little bit of elevation on the tail of the brow. We put 4 cc's in the supraorbital rim and then 4 in the infraorbital. But this elevation that you get in the lateral in the temporal brow without a lift, due to the volume that we placed in here as well as in the temple, I think of it like a pendulum where you have a fixed length of the string, and if you apply force here, in this case the fat creates that force and maintains it, then as long as this is truly a fixed length and the skin isn't too loose and stretchy, then you should get upward elevation. You should get cephalic movement in addition to anterior movement. So what can we do in the future to make it better and try to decrease that downtime, make it more appealing to patients? I've begun using PRP. I started with older patients because they were a little more challenging to get a great result. And PRP, as most know, is platelet-rich plasma, and the idea is that the growth factors that are in the platelet granules may stimulate faster healing and in this case, hopefully better retention of fat. So hopefully we can use less volume and therefore have a lower overall impact size-wise that will take and therefore take less time to go down. So hopefully a week instead of 2. We're now using in all patients in about a 10% ratio, 1 cc of PRP to 9 cc's of fat. And at least so far, there seems to be a trend toward decreased downtime and perhaps improved retention, but we're going to be following that with 3D imaging soon. Do stem cells have any effect? Those of us who do a lot of fat transfer see improvement in the skin at a year or so afterwards. So I do think this is going to be a factor going forward. It's an artist described using nanofat, where basically he showed that there were no viable adipocytes transferred, but still the skin seemed to improve when it was treated in the dermis with fat through a 27-gauge needle. So I think that both will prove to likely have a role going forward. So in summary, volume loss occurs in the periorbital region. I think it's safe to say superiorly and inferiorly, and I think that the superior periorbital region is kind of a novel area that's becoming more popular to treat, and it's a very fun area to treat. It may even be more forgiving than infraorbital region, which a lot of people can attest can be kind of unforgiving. Volume restoration in that area can be very powerful, and I think it's very gratifying both for ourselves and for the patients. And if you're not comfortable with fat yet, then just start with a little filler and do less than 0.5 cc per quadrant. So less than 0.5 cc's for the infraorbital, right or left, and likewise for the superior periorbital. And I don't think you'll be upset with that. And you can always reverse it with hyaluronidase, of course. So, and fat works a little bit longer, so once you get more comfortable with that, or if you're already doing fat transfer, I think it's a wonderful procedure. And obviously we need to be judicious, especially in guys, where I would split these volumes in probably half or third for the same areas. So if anybody has any questions, I know we're short on time, so I'm sorry to go quickly, but feel free to email me, and if you want to come and visit, that'd be great too. Okay, thank you.